Thanks so much for having me. I don't know if I can make grand rounds quite as exciting as Bob Barker, but I do want to ask you some questions today about what things cost in our medical center, hence the title. I have no conflicts of interest to disclose. Here are my learning objectives for everyone in the room. By the end of the talk, I'd like that you understand how Medicare determines payments to hospitals and physicians for inpatient care, that you be able to know the difference between a cost and a charge, and to appreciate the costs of commonly ordered tests and therapies in the hospital. I'd like you to take those facts and principles and be able to apply them so that you can analyze how and why a hospital like ours would lose or gain income on a certain admission, and ultimately to create ways that you could lower costs for inpatients in your domain of care without lowering the quality of care they receive. I'd like to introduce this topic by framing it in a national context. Now, the purists in the audience will probably have to excuse this cartoonist. There's actually only one snake supposed to be there, but these two snakes are chatting, saying, I think maybe we represent spiraling healthcare costs. Not wisdom, not healing, but they're alluding to a crisis we have in this country. We spend a tremendous amount of money on healthcare. In 2010, our nation spent $2.6 trillion on healthcare, which was over $8,000 per person. And that consumed nearly 18% of our GDP. And every year, it continues to grow. And in fact, 29 out of the last 30 years, the rate of medical inflation exceeded that of general inflation. And it shows no signs of stopping. So projections that are fairly rosy with respect to economic recovery and the economic impact of the Affordable Care Act still assume that we're going to be spending close to $5 trillion in healthcare in another decade, consuming about 20% of our GDP. This threatens to harm the federal budget severely, and if you take these projections into the next century, our country will only produce healthcare. So we have a problem, right? We can't keep that up. How is it that we got to this place? Well, I'm going to show you a handful of important explanations. This list isn't comprehensive, but certainly new technologies continue to add to the cost of the care we provide. Our population is aging, and as they age, they have more chronic conditions that they need treatment for a longer period, which is costly. And we have a cohort effect of baby boomers who are entering Medicare eligibility right around now as a group. Our government has expanded insurance coverage, which is costly. And for years, we've lived with a distorted payment system that rewards us for producing high volumes of care rather than high value of care. And finally, we as a nation have chosen to focus on specialty care rather than more cost-effective primary care, as is done in many other countries. And we use hospitals very heavily, which are costly. Right now, about a third of our healthcare expenditures are spent on inpatient care, and it's set to grow to 40% by the end of this decade. And although consolidation in many markets like ours has protected the pricing power of hospitals, it has made us targets for payment reductions. We do need to be aware of that. Now, some of you may be looking at this list and thinking, some of this represents money well spent, and that's true. New technologies have often dramatically improved the health of our patients. And an aging population, that sort of longevity actually should be celebrated in many cases. And expanding insurance coverage addresses the inequalities of the poor health outcomes associated with being under or uninsured. But not all this extra money was well spent. We have a waste problem in addition to a cost problem. All this excess spending compared to other developed countries has not necessarily yielded important outcomes like better infant mortality or better life expectancy. And several healthcare economists suggest that we probably waste about a third of the money we spend on healthcare in this country. I think a nice definition of waste is spending that can be eliminated without reducing the quality of care. It takes many forms. We see underuse of clinically effective resources. We see failures of coordination and delivery of care that lead to iatrogenic harm. We see overuse of ineffective therapies. pricing failure, administrative inefficiency, and fraud as well. When Don Berwick stepped down from the Center for Medicare Services about a year ago, he wrote an article in JAMA describing how, as a nation, if we gradually reduce each of these forms of waste, we can take a curve for the percentage of GDP dedicated to healthcare that's set to just keep rising, and we could flatten it and take that growth away. Achieving that will take a lot of effort on the part of government and insurers, but it also takes a lot of dedication and leadership by physicians. As we heard from Chris Castle from the ABIM last spring, physicians may have unfulfilled roles as professionals and as citizens in convincing the public that we're actually making good choices with their finite resources. And so we should be leading a lot of this change rather than simply looking to government and insurers to accomplish it. And in fact, many other parties are counting on us. There is growing and urgent attention to the value of the care that we provide. We see this now from consumer advocate groups like Consumer Reports and lobbyists like AARP. It's becoming a hot topic for major societies and in major journals. Certainly lawmakers and administrators at CMS or the Center for Medicare Services are keenly interested on the value of each healthcare dollar they spend. And certainly unions, business groups, and the healthcare consortiums that represent business are very worried about protecting the American quality of life and our competitiveness in a global economy. I think a nice definition that everybody's looking at is what's the quality and the accessibility of the healthcare that their beneficiaries receive over the cost. And here at UW Medicine, we face pretty intense pressure to improve the value of the services that we provide. We have a goal this year to cut our costs by about $87 million or $86 million. That means all of us have to do more with less. And I'll tell you, there is waste in our system. The University Health Consortium, or UHC, is a group of academic centers, and they provide benchmarking data for us. Here, this plot shows the cost index, which is a risk-adjusted formula where 1 means we're spending for a given diagnosis the same amount as our peers that take care of the same sick patients that we do. Below 1 means we're more cost-effective. Above 1 means we're spending more to achieve the same outcomes. You can see that over the last year, month by month, both Harborview and the UWMC spend 25 to 35% more for the same outcomes that we would like to compare ourselves to at sister institutions like UCSF, University of Colorado, Vanderbilt, Michigan, the other places that have tertiary referral centers and trauma centers. So clearly there's waste in our system that we can eliminate. And everybody in this room plays a role in this crisis, both nationally and locally. Most of the healthcare, most of the resources devoted to healthcare, 80%, are driven by physician decisions at the bedside. So with each mouse click and keystroke, we're the ones that are determining the cost of care in Puget Sound as well as nationally. Unfortunately, research suggests that we're often not aware of the costs of the choices that we're making. In a survey conducted in Washington State, less than 25% of inpatient physicians could estimate the costs of commonly ordered therapies in the inpatient environment within a 30% margin of error. And I want to make the argument to this group that in order to deliver more cost-effective care, understanding the costs of our decisions is an essential first step. We can't change what we don't understand. And it is really a goal that we want to achieve, not only to address this national problem, but to address problems for patients who are right in front of us. I'd suggest that cost-effective care is safer for patients. It's not the case that more care is automatically better. In fact, it leads to iatrogenesis. And our patients are looking to us as they shoulder an increasing burden of the cost of their own health care to protect them from financial ruin. And finally, we have self-interest in this. Our ability to deliver cost-effective care protects our own resources for the things we care about. Our salaries, our ability to deliver top-notch graduate and undergraduate medical education, our ability to purchase new technologies, and to deliver charity care. So I want to, now that I've framed the dilemma and the urgency of addressing it, I want to put this in a very familiar context for the clinicians in the room. We heard from Tim Ferriss and Chris Castle in the spring about how cost effectiveness can be arranged at a national and a system level. I want to take this down to the care of a single patient, somebody who was cared for on a UW Medicine resident team for the last couple of years, to illustrate the microscopic choices that we make that eventually add up to the cost of care at our medical center. So here's our patient. He's a 69-year-old man admitted for respiratory failure. He was just discharged from our hem-onc service. We learned that he vomited last night and maybe aspirated and became very dyspneic this morning. Medics came to his nursing home and found him tachycardic and tachypneic. So they intubated him in the field and gave him diltiazem for what they believed to be atrial fibrillation. In the ER, a chart review shows that he has diffuse large B-cell lymphoma, and he was recently admitted for chemotherapy that became very complicated. He developed a neutropenic fever that led to sepsis and eventually renal failure requiring dialysis. So that initial round of chemo was very toxic for him. Right now, he has a normal blood pressure. He's tachycardic and afebrile. He's intubated and has coarse breath sounds and is in a regular rhythm, so maybe out of atrial fibrillation, and has no edema or any other findings of heart failure. So at this point, I'd like everybody to grab their clickers and these are the tests ordered by our emergency room: comprehensive metabolic panel, a MAG and a FOS, a CBC, a troponin, BNP, coags, D-dimer, lactate, and ABG. I'd like everybody to vote what they believe is the most expensive test in this panel. And we'll circle back to radiology and microbiology later. All right, I think we're just about at saturation here. All right. Well, so many of you guessed one of the two correct answers. I have to apologize, this was a trick question. But it's going to get to a central point on the next slide, which is that it all depends on who's paying the bill, about who says it's the most expensive. The BNP is the one that costs our medical center the most to run, but the lactate is actually the one that we charge the most to the patient. So if you're paying the bill, you'd say the lactate. But many of you are right on. And this is where I want to distinguish between a cost and a charge, because I think this becomes confusing as people learn about what things cost. They hear different numbers for costs and charges, and it's important to make this distinction. A charge is what goes out on the bill. That's our public price list. A cost is what it costs our medical system to provide that unit of care or testing. And it actually requires a fair amount of accounting support, because it takes into account both its indirect and direct costs. And the indirect includes all the non-patient care overhead required to support the environment that allows that test to take place. I'll give you two examples. A CBC, well, you can't run that unless you pay the electric bill and hire a janitor to keep the lab clean, right? But you also can't run it if you don't have the reagents and the machine and a phlebotomist. Bolusing a patient with a liter of saline, well, you have to have a materials management staff to purchase that saline for you and hold it in stock. And they have to have an IV pump. But you can't do it certainly without the bag of saline or the nurse's salary being paid to administer it. So when we talk about the cost of tests, we're not talking about the strict purchase cost of a single item. We're talking about what it costs our healthcare system to deliver that care, inclusive of all the overhead. And mostly I'll be talking about costs going forward. But let's ask you some more dollar numbers. This is the Bob Barker slide here. How much does a CBC cost us to run? And this is the cost, not the charge. display this? Well, this is actually great because I think that it's nice to see this spectrum of responses. You'll notice there's a couple log difference between the first and the last choice. So what this points out is that we're not all familiar with the actual cost of things. The correct answer here is actually slightly over $20. All right? So about 16% of you were able to guess that. What do we charge for that service? All right, so a little bit closer to the mark here. This year we would charge about $53 for a CBC. So let's total up what's been done. And I'll just point out that we have 2 lactates and ABGs on here because of some sepsis protocol and ventilator change. But we spent about $321 in this initial panel of basic blood work in the ER. And the first thing I'd like to draw your attention to is that all of our basic labs usually have a low to medium double-digit dollar value associated with them. They're all, you can think of every time you're ordering a CBC or a BNP as laying out a $20 or a $50 bill. Okay. Here's what the charge, the bill going out to the patient would be. It'd be about $1,200. And many of you may wonder, well, are we just making a tremendous amount of money off of this care? Why is it that we're charging 2 to 4 times the actual cost across the board? And we don't, I'll tell you. This relates to the history of a variety of payment schemes used by insurers. Once upon a time, like 70 or 80 years ago, costs and charges were pretty similar. There was maybe a little bit of overhead or profit if you were in private practice. And then this resembled the payment. But over recent decades, insurance companies negotiated discounts in exchange for their business. And to avoid losses, medical centers boosted their charges to recoup that payment again. Insurance companies negotiated deeper discounts. We raised our prices, and so on and so on. And what you can see is that now we have a circumstance where the payment hasn't changed a whole lot, but the charge no longer resembles the cost. Now, in the 1980s, the prospective payment system replaced this whole way of doing things for most of the patients we care for, but not all. So the ones who still live in this environment are self-pay patients, patients insured by companies that have older contracts, and out-of-network patients. But most of our revenue now comes from prospective payments. This includes Medicare and Medicaid, and now many private insurers. And rather than looking at the cost of the care we provided and providing some derivative of it as a payment, we get a flat payment for the diagnosis. And it's based on DRGs, or diagnosis-related groups. These are bundles of specific diagnoses. For example, heart failure could be a DRG, which includes 15 or 20 types of cardiomyopathy and various forms of heart failure. There are almost 750 categories of DRGs. Now, in the old way of doing things, if we sent out, again, a long time ago, if we sent out a not very expensive bill, we would get a commensurate but not very much, or not very high payment. If we sent out a large bill, we'd get a large payment. But what prospective payment does is it says, I don't care what you spent on that care. They have this diagnosis. You're going to get this payment for all patients who fall into that category. And it incentivizes us not to provide care at this cost. Okay? So how is the payment determined? Well, there's a formula, and I'll walk through that briefly. And what it starts with is a weight. This is, so you can think of this as a point system. It accounts for the clinical complexity and what Medicare believes will be the expected cost of providing care for that diagnosis. It's multiplied times a base rate, which is what our hospital gets paid per point, and it's adjusted for local wages because it's more costly to deliver care in Seattle than it is in a rural area. It's adjusted for our proportion of uncompensated care and how much medical education we provide. And that's our final payment. So here's an example with some loose numbers to give you a sense of what might take place to this patient who we're going to say maybe has aspiration pneumonia and sepsis. So we'd get 1.2 points of weight for diagnosis of sepsis. And he's on dialysis. You're allowed sort of one opportunity to bump it up with a short list of major comorbidities. And because dialysis is costly to care for, we do get that accounted for. In Seattle, we might get a payment around $6,000 at a baseline for a hospital. And then the fact that we deliver charity care and medical education would mean that our hospital might earn around $9,000 or $10,000 per point. So what we can tell you already is that this patient is going to, what we're going to be paid for his care is about $18,000. This is essential. We know from the second we make a diagnosis what we're going to get paid. And every test we order from that point forward is actually money coming out of our pockets, not out of the patients or the insurers. It's our own money we're spending. This patient is at the bedside and says, I can't afford that diagnosis. Do you have a cheaper one? And what this points out is it's also important what we document. So we won't get paid for more complex care unless we write it down. And so the diagnoses that we make in our notes are essential to getting the right weight associated with that note. So let's come back to the patient. We spent $321 on lab testing. What did we learn from that $321? Well, I'll summarize the abnormal labs. An elevated white count, an elevated creatinine, an elevated lactate, a D-dimer, a low albumin, and a high total protein. So the ER was concerned that this patient probably had sepsis, maybe from pneumonia, and they proceeded to order some microbiology tests and eventually some imaging. So I'm going to pull you back in with your clickers here and tell me, what does the standard blood culture times 2 cost our medical center to perform? All right, some elevated guesses. Nobody picked the really inexpensive one. It's actually about $100 or $97 this year. And that's before any speciation and sensitivity testing is performed, which add additional cost. The charge for this, incidentally, would be about $250. But here's what was done for this patient. Urinalysis, pretty inexpensive at $15. A urine culture and gram stain, which produced an organism, so it had additional costs to work that up. Same with the sputum culture. And unfortunately, the ER drew 2 blood cultures, and the admit orders asked for 2 more, so a few were drawn just a couple hours later. So we spent a lot of money on bacterial blood cultures. And this tallies up to $450 of microbiology care. Now, the ER was concerned that this patient's respiratory failure could be due to a pulmonary embolus. They had checked the D-dimer, which I'm not sure how helpful that was in the setting of active cancer and potential sepsis, but it was high, and perhaps that led them to order a CTPA. So what does a CT pulmonary angiogram cost us to perform? There's a nice distribution of responses here, which I take to mean people aren't sure, or they've heard conflicting things. $450 is about the right answer. We charge about $2,200 for this service. Okay, so here's what happened for this patient in the rest of his testing. His endotracheal tube had to be repositioned, and he had a central line placed, so that's why 3 chest x-rays were necessary. And actually, the cost of a CTPA varies with the volume of contrast infused. So his came out to $445. So we spent almost $700 on imaging and did an EKG. There's no hospital charge for that, but a cardiologist who reads it will submit a physician bill. So let's review what this next about $1,000 of spending has bought us. Well, we've confirmed he's in sinus tachycardia. His urinalysis suggests he might have a urinary tract infection. There's nothing in his bloodstream that ever grows out, but his sputum shows a very high colony count of Klebsiella, and Pseudomonas grows from his urine. Chest X-ray shows bilateral consolidation. The CAT scan confirms he does not have a PE, but confirms the multilobar pneumonia with some lung necrosis. So to put this all together, it does indeed seem like aspiration pneumonia with sepsis. And that's what our about $1,500 of workup in the ER has yielded. I'm going to rapidly explain what happened in the rest of his care. He went to the intensive care unit, got a central line, IV fluids, antibiotics, pressors, ventilation, and due to really competent care, bounced right back. He was extubated the next day, dialyzed, and seen by therapists who recommended a nursing home. His blood culture, or rather his cultures, yielded an organism to which we could tailor antibiotics. He was transferred to the floor. Social work is trying to find a SNF for him. And then we enter Saturday of a 3-day weekend. Has this happened to anybody? Okay, just checking. But he's actually in great shape. His white count's normal, he's afebrile, he's on room air. By many criteria, he might be ready for discharge. His DPOA visits a couple of SNFs, and one is arranged, and then on the next day, he says, you know what, this isn't what I want. I'd actually like to go to inpatient rehab. So rehab consultation is performed, and another 2 days later, he goes to inpatient rehab after all. So our patient came through the ER, was intubated in the ICU for 2 days, was diagnosed with sepsis, and spent not quite 9 days, 8.5 days in the hospital. What does all this cost? How much of our resources did we spend to deliver those 8.5 days of care? Okay. Well, at least nobody fell for 5,000. It was just over 19,000. 19,000, about $600. What do you guess the bill that we would send out for this care would be? Okay. Almost half of you thought we were going to send out a pretty monstrous bill. It actually isn't quite that bad. It's about $45,000 in this case. And again, as you recall with Medicare, this actually is going to have no bearing on what we actually get paid. So how do we tally this up? We sent out a bill for $45,000, but we only got paid about $18,000. We expended over $19,000 of our own resources, and we lost, at the end of the day, about $1,400. You might think that I had picked this case somehow to cherry pick an interesting learning case, but that's not true. This histogram points out the cost of providing sepsis care to Medicare beneficiaries in the academic year in which it was done. And this was actually the median cost for all those patients. So if this is our average way of doing business, we can't sustain this for very long. So some people wonder about the ones on the right. These are patients who have died very swiftly and have negligible costs associated with their care. So let's break down the costs by category. I want to drive everybody's attention to the bottom line. The room cost far and away drives the cost of care more than anything. And that accounts for, paying the mortgage and all the things it takes to keep a bed open and staffed around the clock It's expensive, but also dialysis. We continue to order daily labs. A lot of medications were dispensed from our pharmacy. Therapies are actually not inexpensive. And then the microbiology and radiology we already talked about. This is about the cost of the hospital care, but what about the physician? That was one of the other learning objectives, is how do they get paid, because it is separate. Now, this slide for the attendings in the room, this is going to be not news to you. This is really for the benefit of students and residents to catch everybody up to speed. But physician and hospital revenues are separate, and the physicians are billed to Medicare Part B. Our charge is determined by documented complexity or the time spent. And like the weight system used for hospitals, our notes are assigned an RVU value, or relative value unit. It's just another point system that eventually translates into a dollar payment. Different payers may reimburse at different rates, but Medicare in that year might have paid around $34 per RVU. And this slide shows some selected examples of notes that were, excuse me, that were written for this patient and how many RVUs they might have generated. I don't have how much we got paid, just what we would have charged. There are 3 levels of H&P, basically low, medium, and high complexity. This is a high complexity admission that garnered the most RVUs. You'll see that an EKG, which certainly takes a lot of skill but can be done relatively quickly compared to an H&P, only garners a fraction of an RVU. A central line was placed, but incidentally it was only tacked in as a sentence in the H&P. Nobody wrote a procedure note. And so we lost an opportunity to bill for that expertise that we provided. The radiologist reads the CT scan and adds a charge to the facility charge. And then every subsequent day, we delivered sort of medium complexity daily notes, with a couple of exceptions. There were some important missed opportunities. One of the days in the ICU, the attending didn't sign the note, and so we can't bill for that. So a lot of work was not compensated. Another day, a resident left an exam out of the daily note. So all the other effort that went into that patient's care was reduced because we could only bill at a low-level note. So when you add up all the departments that interacted with this patient, we would have sent out a bill for about $3,600. And we don't have actually what we got paid, but a typical Medicare payment for those bills would have been around $1,600 for all the work we did. Just to review, the differences between hospitals and physician billing. Hospitals have a capitated and prospective system. We're paid for every admission, and that rewards efficiency in providing cost-effective care under the cap of what we're going to get paid. What we get paid is determined by the DRG system and its buckets of ICD-9 codes, and it goes to Medicare Part A. Doctors bill on a fee-for-service system. We're paid for each day. This rewards note writing rather than efficiency. We just get paid every day that the patient sits in the hospital, which is actually counter to what the hospital would like. We're paid on an RVU system determined by CPT coding and billed to Medicare Part B. Here's Uncle Sam having a healthcare procedure. And we really don't want to get to this point, right? We don't want the public to view what we do and the passion and the care with which we deliver healthcare to be mixed up this way. So I want to present this case now from a couple different perspectives. How else would the other people involved have seen this? This patient got better after rehab and he went home. When he got home, in his mailbox, he would find an explanation of benefits, Medicare summary notice, and his bills. And his deductible that year, which had not yet been covered because it was early in the year, would have been about $1,100 for this care. He also would have had to pay 20% coinsurance on the physician bills. And I wasn't able to determine what his outpatient prescriptions cost him or where he was in the donut hole of Part D of Medicare. But what we can say is that this patient's life was saved, and he went home and had a bill for about $1,500. And we don't know if that felt fair or right to him, but that was his experience. What if we see this from the view of a healthcare executive? Well, they might be focused on different things about how would we minimize costs here to avoid losses. We could use fewer studies, perhaps, to achieve the same outcomes. What if we use less costly but equally efficacious drugs, generic or PO whenever possible? What if we shorten the length of stay? And I'm just going to skim over the issue of quality and satisfaction, which increasingly modulate the amount that we get paid through value-based purchasing, but would be of critical concern as well. An executive also might worry, how could we optimize our reimbursement across the board? How could we make sure we get the most complex patients to care for? How can we keep our hospital busy so we don't have empty beds that aren't generating revenue? How can we document better to capture all the complexity of the care that was delivered to this patient and others? And how can we find a way to make sure that we have a good mix of payers so that we have patients with private insurance as well as Medicare and Medicaid? And what about from the physician's perspective? We made a whole series of decisions that all had costs that added up. Where could we have changed this and yielded the same benefit? Well, I want to highlight, this pie chart shows the data I had a few slides ago just in graphical format, and it really portrays how important the length of stay is. The hospital bed drives most of our costs, although certainly other things account for the other half. And I would argue that this patient stayed at least 3 days beyond what was medically necessary. Each day he was here, we had a cost for a hem-onc bed of about $1,100. We dispensed our medications and did daily labs, adding up to not quite $1,400 per day, or about $4,000 for those last 3 days that he was here. That $4,000 right there represents the whole difference between losing our resources on this admission and actually gaining resources that we can spend on other worthy projects. And so I would suggest that right off the bat, the greatest opportunity would have been to figure out how to have a conversation with this patient that would have determined early on in a very patient-centered way, where do you want to be? What's the care you want to get in a few days? What's the setting? And to have tailored that discharge right from the get-go to those needs. But we could cut costs in other arenas as well. What about labs? Most of what we spent was actually basic daily labs and microbiology, although there are a smattering of other expenses in our total lab costs. And I saw a lot of opportunity here. This patient had twice daily labs for several days in a row, but he had no metabolic disarray. He wasn't bleeding. We could have just done daily labs. And we could have stopped them entirely for the last 3 days when we thought he was going to be discharged anyway. That would have saved $139. We ordered a mag and phos every single day. What if we only did that on dialysis? $210. We ordered LFTs every day. They were equally abnormal every day, never changed, and we never did anything about them. We could have saved a paltry $8. Not a lot, but it's the principle I want to get at here. I think equally sort of senseless. This was a man who was not on Coumadin, yet we proved with his admission coagulation parameters he was not in DIC. Yet we checked an INR that was 1 or 1.1 for 9 days in a row. So why? We could have saved $77 there. And some might have said, well, here's somebody with no history of heart failure and no physical exam findings to suggest heart failure. Maybe a BNP wasn't helpful. And also here's somebody with active cancer and suspected sepsis. Is that D-dimer going to be anything but elevated? With fairly rational lab ordering, we probably could have saved about $570. What if we review the way we use medications? Most of it was spent on antibiotics and anticoagulants and a fair chunk on erythropoietin. Just a couple of opportunities here. If we had used unfractionated heparin instead of enoxaparin, we could have saved $147. And we knew pretty early on that he didn't need IV antibiotics for a full course. We could have switched him to a pill. If we'd done that for the last 4 days, we could have saved another chunk. In total, I think with very rational laboratory medication and bed use, we could have saved about $5,000 on this gentleman's care. I want to be clear that I'm not suggesting that this man have bypassed the ER, but let's just suppose that he could have, because that also has costs. And patients who don't need to be in the ER slow down the care for everybody else. So when you're looking at a patient who could go from clinic or home straight to the floor, you might save, as we theoretically could have in this case, around $500 across the various IV, venous access, and ED fees associated with that care. So I want to summarize in fairly general terms what I hope I've taught you about ways you can save waste or avoid inpatient waste. If you can, stop daily labs when they're not needed. Use generic or PO medications whenever possible. Avoid studies that were recently done or unlikely to change inpatient management. Or in other words, don't order that MRI on the last day just to convenience the subspecialty team. Avoid the ED when it's safe to do so. And avoid hospital complications. We won't get paid for them in many cases, and they extend the length of stay. In addition to them being a major problem for the patient that we should avoid. And plan for discharge early to minimize the length of stay. Beyond these general recommendations, we're seeing a steady stream of literature emerge to provide much more concrete disease-specific recommendations. A lot of this is emerging from the ABIM and its associated organizations. And this is a screenshot of one of the Choosing Wisely pamphlets. These are called 5 Things Physicians and Patients Should Question. Every major medical society now has released one of these or is in the process of preparing one. So you can find them from not only the ACP, but professional societies for radiology, cardiology, nuclear medicine, allergy, immunology. And I don't want to actually go through these except to say that these are disease-specific. You can absorb them in a short amount of time. Think about whether they apply to your practice. In fact, they may form the basis of ways to measure cost effectiveness in what we do on a daily basis. We can also turn to major journals. So we now have the Less is More series in the Archives of Internal Medicine and the High Value Care Collection. And just last month, the Institute of Medicine released a report called Better Care at Lower Cost. In addition to picking specific ways that we can reduce costs for healthcare, they really emphasize the need for IT support to drive clinical decision-making to the bedside so that there are personalized, evidence-based decisions within the CPOE or EMR environment, and also that all of our IT resources be used to generate reports so that we know about our own behaviors. Right now, it's actually really hard to figure out what your ordering behaviors might be. That's changing, though. And as an academic center, we have an obligation to train the next generation of physicians to be much better stewards of medical resources than we have been in the past. I like this etching by Rembrandt about an anatomy lesson, especially because of these 2 gentlemen in the middle who are just hanging on every word and gesture of this anatomy professor. I wish that I could enthrall my trainees this well. I don't, but what I do know is that my actions matter. What I model, the decisions I ask for my teams to make will affect the behavior patterns of students and residents going forward. So I would turn to the attendings in the audience and say, how are you at modeling restraint and asking for good stewardship in your day-to-day care? Because it really matters in what our trainees absorb from us. And we actually know from a pretty sophisticated study done at the University of Pennsylvania that there is a huge amount of variation in how our trainees order tests in the hospital. This is a study that looked at 10,000 patients on the University of Pennsylvania General Internal Medicine board teams over a several-year period. And through some fancy statistics, they were able to try to parse out what portion of the variation in lab ordering habits was attributable to different team members. And the bulk of it, about 70%, is due to house staff, in fact. 20% they couldn't pin on anybody, and only 9% could be attributable to the attending. I think we should turn that on its head. The attending should be helping to model a way to reduce variation so that everybody's having standard and cost-effective practices. We know that education in this area does matter. A randomized trial just published last year at the Brigham Internal Medicine Residency, in which the intervention was simply a 45-minute lecture, probably not unlike what we're talking about now, paired with a cost analysis of one case of a resident's care, and a pocket card on ways to avoid excess costs in lab and medication utilization, managed to demonstrate over the course of a year an average savings of $163 per patient in the intervention resident line. Now, I should point out the caveat that they weren't able to detect a statistically significant change in the total cost of care. So this isn't going to change everything. But it does point out that talking about this and asking residents to change behavior actually does affect lab costs at a minimum. And there are organizations that are really pushing the envelope around this, right? So UCSF has a $1,200 payment allocated to each resident and fellow for their performance on quality metrics. And in a recent year, what they paired it to was each resident and fellow's performance on hand hygiene and their utilization of CVCs. And in that year, they were able to decrease the use of CVCs by 5% across their entire organization. And the savings actually went to the residents and fellows who achieved this. So there are really some forward-thinking systems out there. Around here, we're starting to get more information about our own practices. So this will be coming from CareFX, and I don't know, actually, can I see a show of hands? Who's heard of CareFX? Okay, so maybe half the room, I think, or maybe a little more, which is good. This is a screenshot of what it looks like. It's a University Health Consortium product. And on the left-hand side, it shows all the divisions or departments. And along the top, it gives indices. Like I was saying, that cost index compares our cost of care to that of other major academic medical centers. So we can compare our length of stay, our cost, our mortality, our readmission rate, our patient safety events across divisions. But if you click on an individual division, and I didn't ask my colleagues if they wanted their data shown here, so I covered them up. But this is by physician. So you could figure out what your length of stay and cost index are for your own personal care. So for the people who aren't familiar with this but are attending physicians, consider talking to your division head about this. So this is a little fanciful, so humor me for a moment, but I want to tie back to the very, very beginning and just sort of dream a little bit. What if this patient I showed you was like every other patient we admitted, and we were able to trim $5,000 of costs from their care? Well, you know, $1 million here, $1 million there. Pretty soon you're talking about real money. $105 million could have added up, and it could really fund a lot of the things that we want to provide at our medical centers. Or even more fanciful, if we had saved $5,000 on his care, it would have been about 25% of his healthcare expenditures. What if we did that across the whole nation? Well, $750 billion, we wouldn't be arguing about the fiscal cliff, right? There'd be a lot of things different. We could be arguing about how we're going to spend the windfall on education or roads or something else really wonderful. So I have two more slides. The first is to acknowledge some really critical people, especially Lauga Sokol Hessner and Chris Vanderwalker, who worked with me on this slide deck in an earlier format. None of us could have done this without outstanding support from Mo Broom, Keir Swanger, and Gladys Wanu at the finance department. I needed their help to figure out all the line item costs of this patient's care and to actually understand what it all meant. And I'd also like to thank Tom Steger, John Amory, and Brad Anawalt for being outstanding career mentors to me, but also for helping me to think about cost and quality issues in the hospital. I have just enough time for the last exercise that I want to do before questions here. I'd like everybody in the room to start, and we're going to have a minute of silence for this. All right? Think about a way or two that you can apply what I've taught you today to lower costs without affecting quality in your environment. After that minute's up, I'm going to have you turn to your neighbor and share your ideas briefly with each other. We're going to have 2 minutes for that, and then